And they're always hanging out together, so they're at high risk of, sorry, go ahead. Oh, yeah, children are at high risk of potentially getting a respiratory illness. And here I want to cover what most define as the flu season. The flu season is caused by a virus and not necessarily the cold weather. I know there could be a misconception there with people associating the cold with how people get the flu. What what it really is more illnesses happen in the winter because people are spending more time indoors and together in close contact together. So, especially for children in schools and daycare, this is really pertinent. And this is why there's that kind of flu season typically in the winter months. Um, and then viruses spread more easily in dry and indoor air as well. So, I have a quick pop quiz here for anyone to answer, but what is the supposed to say common, most common cause of hospitalization for respiratory illnesses in infants? If anyone wants to maybe put down an answer in the chats or shout it out.
All right. So first in the answer in the chat was
Um,
A. You can look in the chat there, Akram, figure out
yeah,
who
I'm looking right now.
who answered correctly
Got an
first.
A, couple C's, one B. Okay. The answer is actually D, RSV. I don't know if anyone in the chat was able to get that one. And this is why, oh, some some people did say D. Don't know if that was before or after I said it. But RSV is something I really wanted to cover here because one, people may not know what it is, and two, it is a really common infection that can turn pretty bad as well. And what RSV stands for is respiratory syncytial virus. Um, and it's a very common respiratory illness. Almost all children get it. And I think what's interesting about it is it mimics like common cold or flu-like symptoms. So you get the runny nose, the mild cough, low fever, congestion. But what makes it different is that it's able to move down into the lungs. And it can cause some of these abnormal lung sounds like wheezing or fast labored breathing. And that's what makes it also a little bit more dangerous, if I want to use that word, than a common cold or flu may be as well. Dr. Capella, I don't know if you want to add anything to that right there.
I think just the most important thing that I tell families is that RSV is basically just presents like the common cold in older children and in adults, but in babies, especially under a year, and in the elderly, it can be just a really bad cold. And it can cause so much mucus that the mucus plugs the airways of little babies. Little babies, of course, they're so small that those airways, the little tubes that carry oxygen to your lungs, are so small that they can get plugged with that mucus. And so something that might just be a cold in a 7-year-old or in a 25-year-old might be this, really bad cold that leads to hospitalization in infants, especially the first few months of life. So just being careful during the winter time of like, it might just be a cold for you, but if you're around any young children, be really, really careful.
Definitely. And that leads on to the next slide of things you can look out for, be on the lookout for some of these warning signs to let you know that your child may be under respiratory distress. This doesn't necessarily mean they have, RSV because you're hearing something like wheezing, but it could be the start of an investigation of what may be going on. So, wheezing, what is wheezing? Wheezing is a sound it's a high-pitched sound. It's usually heard when you're breathing out. It comes from the chest and lower airways, and it's caused by the narrowing of those airways. And so this is why wheezing is most commonly associated with asthma, because what's happening with asthma is your airways narrowing, causing that high pitched sound? And so here I have a video that demonstrates what wheezing may sound like in a baby. So you can hear that high pitch.
Don't know if people can hear it. This is sometimes the issue when things are embedded.
Is everyone able to hear that? Just let me know in the chat. No audio.
Yeah.
Ooh. Hmm.
So sometimes what you can do is stop sharing your slides and then share again. And when you share, you have to check a little box that says optimize audio for sharing or something like that.
Yeah. And I
Yeah.
didn't know you had video. I would have done a run through on that.
I'm looking for that optimize audio option here. Let me see.
I think it was
Sorry, guys.
a box when you shared, like when you went to share screen, there should have been a box that you check before you share. That's where it is.
Hmm. Maybe if we can't figure this out, maybe I can send the completed slides out and we can send those out and people can kind of hear those sounds, but I can just go ahead and kind of describe some of the stuff in the videos too.
Yeah, just describe. That's fine.
Yeah. Okay. So yeah, wheezing is that high pitched sound and you'll hear it on the exhale. And maybe I can try to even mimic these sounds. It's kind of like a okay, that was a bad representation, but kind of just imagine a high pitched sound with that. Retractions. This one, luckily, we don't even need sound for this one, but this is when your skin starts pulling in between the ribs, and this is happening because your child is trying to is working extra hard to breathe. They're really struggling to get that air in, and that looks like their skin is pulling in between the ribs. And here you can kind of watch and see what that looks like. Kind of in this area right here, you can see that. And that's your child's muscles basically trying to pull in and suck in as much air as they can.
At what age can you begin to see retractions?
To my knowledge, you can see them, as early as an infant, but Dr. Capella, maybe you could speak more to that.
Yeah. For really young infants, maybe like, only a month or two, they don't have that much musculature in their chest, and so they can't necessarily, do that very much. As they get older, they develop more musculature and more ability to really show that. But in an infant, one of the scary things about RSV is that they can just stop breathing. Like they can become apneic. And so you wouldn't even necessarily see really clear signs that they were sick before they just couldn't stop breathing. And that's one of the reasons that we have developed the RSV vaccine, because it is so dangerous in babies. And I know you're going to talk about that later.
Yeah.
Yeah, go.
And Strider, you can kind of imagine Strider like wheezing, but instead of the sounds heard on the exhale or breathing out, you'll hear them when the child breathes in. So it's very similar to wheezing, but just different of when you hear it. And the difference in when you hear it just really depends on where the obstruction is in the airway. And so this is going to be, from the upper airway or the throat, and that's also going to be a narrowing, which causes a high pitched sound. Now you don't. You guys can't hear it though, so we'll go to the next one. Grunting. This is another sound you can hear. It kind of sounds like a sound.
I can
And it's
imitate it
harsh.
for you. So kind
Yeah.
of like they're trying to breathe and they're going, "Uh, uh," like they're like trying to get the air out, and they just have to kind of like push extra, almost as if we were like, running track or just trying to catch our breath or like breathing like that. So it's that expiratory force that you hear.
Yeah. And all of this is just signs that there may be an obstruction in the airway or it's hard to get air in, and it can lead to well, we need to start investigating what it may be.
Yeah, by the time you get to grunting, you got to go to the ER. That's one of kind of the signs where it's getting really labored to breathe. The child is working too hard. If a child has to work that hard to breathe for too long, they can go into respiratory failure. So by the time a kid is grunting, take them straight to the ER.
Yeah, Croup, this one I'm really sad the sound doesn't work. I think it's an interesting sound and maybe a unique sound. And Croup is a diagnosis. It's not a sound, so I correct myself there, but it's characteristically described as a barking or a seal-like cough. Um, this one's gonna be hard to mimic, but I'll give it my best. Maybe like a ooh type of sound. I
Yeah,
did
that
my
was
best
that
there,
was a
but
good one. Yeah, it's like a seal barking, ooh, ooh, that deep, like it's not just a regular cough. It has like a different resonance to it. You did it pretty well.
yeah. And interestingly enough, cold air can help with croup a little bit, which was interesting to me. I didn't know too much about that, but what are some of the other things you could do to help with croup, Dr. Cabela?
Yeah. I mean, if it's just mild croup, really just supportive stuff like humidification, taking them out to the cold air. Lots of times with croup, what happens is the child seems okay. They just kind of have like this cough during the day, and then suddenly they take a nap and they wake up with like trouble breathing and this really barky cough, or they wake up in the middle of the night, and that can really scare parents because it's happening in the middle of the night. Doctors' offices aren't open. They don't know what to do. So one of the first things to do is take your child outside into the cold air, or if it's not cold outside, you can open the freezer door and let them breathe in that cold air from the freezer. It's something about the cold air that improves laminar flow through the airway. And so that's one of the really easy tricks to do. Also, trying to keep your child as calm as possible it is helpful, although that's more challenging than parents would like, to keep them calm when the child is coughing and crying and everything. If it's to that point where it doesn't just self-resolve with some cold air, then going to urgent care, going to the ER is important, because croup in certain, especially the younger children, it causes inflammation around the airways. And so that airway can actually close in really severe cases. And closing the airway means you can't get oxygen, you can pass out. I mean, kids have died in the past from croup. So it's not necessarily that common that it gets that severe, but it can get that severe in some cases.
Okay, here I just have a table kind of breaking down viral and bacterial infections and some of the common ones in both. So I can start off with the viral side, which you'll see the common cold, RSV, flu, COVID. These are some of the more common viral illnesses, and they're especially common in children for the reasons we discussed earlier. Children are, touching everything, they're around each other a lot, so it's a lot of time and opportunity for these viral infections to spread. Importantly, antibiotics do not work with viral infections, and that's an important thing to understand, especially when it comes to treatment and potentially putting your child at risk of getting more infections by giving them antibiotics when they don't need them. But some of the ways the doctors test for viral infections are nasal swabs, and I've heard viral panels. I know some viral panels have specific viruses on it that they can test for, and I think RSV is one of those on the viral panel, if I'm not mistaken. But over to the bacterial side, common ones are that's strep throat, pneumonias, and ear infections. These may require antibiotics, and again, some of the ways that doctors test for them: throat swab, chest X-rays are really big for pneumonia if it's suspected, and also an ear exam, like looking into the ear. there. Anything you want to touch on there, Dr. Capella?
Mhm. I mean, I'll just say that sometimes it's a little tricky to tell the difference, but most of the time when someone presents with a fever, with a cough, with runny nose, with congestion, your doctor's going to check ears to make sure it's not an ear infection. Check your throat to see if it's maybe strep and listen to your lungs to rule out pneumonia. And so if they find one of those, then maybe they'll say, hey, might be a bacterial infection. 99% of the kids that I've seen in my career, thousands and thousands of kids with fever, cough, runny nose, sore throat, congestion, have viral infections. So that's not to say bacterial infections don't exist. It's just, especially in young, healthy children, it's hard for that bacteria to really settle in. Even ear infections nowadays, the recommendation is for most kids is not to jump straight to antibiotics. And so parents will sometimes text me and say, hey, so and so is, tugging at his ear and seems to be in pain. And I said, you know what? Just do some ibuprofen. And ibuprofen is great because it has anti-inflammatory properties for the ear. So it helps to reduce that swelling and that pain. And and I tell them do that for 2 days. It's called watchful waiting, like someone put and like Richard put in the chat. And that way, it gives the body time to maybe self-resolve the infection. Decades ago, we used to just jump to antibiotics all the time with ear infections, and a lot of kids that were kind of getting their gut messed up with antibiotics, especially frequent use of antibiotics. Nowadays, we have this watchful waiting, except in certain cases, like kids with immunocompromised conditions, really young infants, but pretty much everyone else, even when they have an ear infection, we recommend watching and waiting for 2 days with pain control and other measures before we jump to antibiotics. And about 80 to 90% of the time, it will self-resolve.
And there's another question in the chat right there for you.
Yeah, Dr. Ferguson says, do you believe in post-dated antibiotic scripts for ear infections? Yes. When I worked in urgent care, I did that all the time. So what I would do is I would say, hey, I know it's really hard to just come back and wait for 2 hours in the urgent care line. You don't want to have to do that. So what I'm going to do is I'm going to write you a prescription. Your child's ear does look like it has an ear infection, but we can do this watchful waiting. So I'm going to send a prescription to the pharmacy, and there's a note on the prescription to the pharmacist that says do not fill until such and such date if needed for persistent symptoms. And then the parents just have peace of mind that they don't have to try to, make their way back to a doctor and schedule a visit again. What if it's the weekend? What if it's the evening? If they have that script and it's been 2 days of pain control and their kid is not feeling better, they know that they can go and get that antibiotic. They can get that amoxicillin. Amoxicillin is typically the one that we use unless a child is truly allergic to the penicillin family.
Okay, we have another pop quiz. Your child has a runny nose, cough, low grade fever, and they're playing and drinking normally. Should they start antibiotics? Yes, no, or just in case? So we have a yes, we have a no, couple yeses, couple no's, and no. They should not start an antibiotic. Kind of goes back to what Dr. Capella was saying a little bit. You said even in bacterial infections, they may not be starting antibiotics. And it's because bacterial infections or antibiotics have been shown to have the bacteria start getting resistance to it. So basically, when somebody is exposed to a lot of antibiotics, they will be resistant to them and actually more susceptible to infections in the future. And that's why we try to limit antibiotics.
Yeah, definitely. And in addition to that, the antibiotic resistance is a big deal, right? Really important to only use antibiotics when your body really needs them because of that resistance developing, not just in your own body, but on a community level. Overuse of antibiotics leads to more and more resistance among the whole population. Another reason is that your whole intestinal tract, right, the hundreds of feet that comprise your intestinal tract, also have a very complex ecosystem of healthy, of beneficial bacteria. that helps to digest and absorb your food and contributes to health of your gut. And your gut is tied to your brain, is tied to your immune system, is tied to your mental health, is tied to your endocrine system and everything. So whenever you take antibiotics, you're not just killing the bad bacteria maybe in your lungs that's causing pneumonia, or in your ears that's causing the ear infection, or in your throat that's causing the strep. You're also killing off a lot of those beneficial bacteria in your gut. And that can lead to diarrhea, that can lead to the overgrowth of other different species of bacteria in your gut. And over time, if you do that too much, especially unnecessarily, you can start to have gut issues, which can then affect all systems of your body. So that's another really important reason. Also, with this question, it just kind of brought to mind growing up. I grew up in a Mexican American family in Los Angeles, California, close to the Mexico border. My family had a grandma in Mexico, and we would go visit her all the time. And my family would go and buy antibiotics like penicillin injections and amoxicillin from those Mexican pharmacies. And sometimes when we would get sick, they wouldn't do it if we just had a runny nose, but I remember my mom giving us, some of us, injections in our butt of penicillin, because there was just this really common community myth that every time you have a high fever or every time you have a sore throat, you need an antibiotic. Maybe a long time ago, before we understood viruses and when really serious infections were more common, it was scarier. But nowadays, because of vaccines that prevent a lot of those serious infections in a person who is fully vaccinated, we don't have to worry as much as we used to. But there's still, especially with like certain populations, like the population I grew up in, there was this myth that, you should jump straight to antibiotics for almost any infection. And unfortunately, as I just mentioned, it has some not so great effects.
Yeah, it's interesting that you say that because I have similar experiences too, growing up in an African household. I grew up in Uganda, and same thing is they would buy the antibiotics over the counter over there, and we'd use them as well. Really, this whole presentation is me like addressing my mom's misconceptions and stuff like that, and and I think a lot of people might have the same misconceptions too, like in our communities, Black Hispanic community as well. So I think it's important to address for sure. Uh, okay, so what can we do to prevent this? It's hard to enforce washing hands with soap and water with children for sure, but if somehow you can get your child to get going with these good habits, they can help reduce the spread of some of these illnesses. Cover coughs and sneezes, stay home when sick. This one's big. This is how you prevent it from really getting to other kids. And typically the recommendation is waiting 24 hours until you're symptom free, being symptom free for 24 hours before returning to school. Just cleaning touch surfaces, keeping up with vaccines, avoiding contact with sick individuals. Um, these are opportunistic infections, so some of these things are a little bit hard to control, but what we can control are some of the things on this slide, and we could work towards that to kind of help minimize the spread.
It can be really hard with kids, telling a 3-year-old to cover their cough almost never works. But I agree with you, Akram, like that the state keeping your kids home, especially when they're sick, and you yourself. I know sometimes we're like, but we have a test or we have to go to work or we have to. Well, if you're coughing a lot, but you have to go, then wear a mask, right? I know not many people loved wearing masks during, the peak of COVID, but it really does help to reduce the spread, and that frequent hand washing when you're sick, especially, can help so much. Because a lot of us, we're not even aware that we're like touching our nose, but we just do it out of habit. And that's spreading those germs that then, we touch a doorknob. I'm actually a little bit of a germaphobe during winter season, and I always open doorknobs with my elbow, or I grab like my shirt, my jacket, and use that because I know that I touch my face frequently without even thinking about it. And if I'm touching a doorknob that 100 other people touched in the last hour, guess where those germs are coming from, right?
Mm.
with kids, keeping them home. Sometimes the coughs during the wintertime illnesses can last like 2 to 3 weeks. And so parents will ask me, am I seriously supposed to keep my kid home from school for 2 to 3 weeks? The answer is not necessarily, right? There's going to be the peak of the illness when they have the fever, when they have the intense cough, when they have the runny nose and congestion and sore throat, right? So typically I say, the minimum rule is until they're fever free without medicine for 24 hours and feeling significantly better, right? They don't have to be 100% because those coughs can linger for 3 weeks and it's just post-infectious inflammation of your lungs. It doesn't necessarily mean you're still contagious, but definitely fever free for 24 hours and feeling a lot better.
Treatment. Treatment is very limited, and this is hard for a lot of parents to hear and a lot of people to hear, but um, really just a lot of this is going to come down to rest, maybe isolation, fluids, and if it's a confirmed bacterial infection, maybe antibiotics. And this is what's tough is kind of letting the illness run its course. And watching maybe your child go through an illness and maybe suffer through one maybe isn't the easiest thing to witness, but this is just something that their body and their immune system is going to have to clear on its own, usually. And then I want to talk about vaccines really quick. So vaccines help prevent serious respiratory illnesses like flu, COVID, Tdap or DTaP, uh, pneumonia, RSV. And I wanted to demonstrate or show off some graphs here. It's a little bit hard to see, so I'll describe them. So here on the bottom or the x-axis, you see it's really just increasing in age. And up here on the y-axis, it's basically infants that have had no events or no kind of like rest hospitalizations or symptoms associated to RSV. So all these graphs are for RSV here. And the blue line is is children that have the RSV vaccine, and the red line is people that have either the placebo or they don't basically have the RSV vaccine here. And I think it's important to note the difference here in the percentage of infants that are showing up with some of these symptoms, like a lower respiratory tract infection or severe hypoxemia, which basically just means low oxygen. Um, the difference here, I think, can help us visualize why some vaccines or why vaccines are so important in preventing the spread of illnesses. And this is just for RSV. I imagine that a lot of other uh, vaccinations have a similar, similar trend.
I'll just make a quick note of that. The RSV vaccine we used to give only to premature infants because they were at the highest risk. So if a baby was born 2 months premature and they were in the NICU for 6 weeks and then they finally got discharged home, we would give them the RSV vaccine because their lungs are already born premature, already at risk for all sorts of infections because of the prematurity. And then we would send them home and say, hey, even though this vaccine, I think it was something like $2,000-$3,000 per dose, we would give it to them and they would get an injection every month up until a certain period of time to protect them because they were a very vulnerable population. Now that worked so well that we said, hey, what about these babies that aren't premature, but they're still at risk of getting hospitalized and even dying from RSV in those first 8 months of life? And so we did analyses, population studies where it was like, okay, at what ages, up until what age is a baby's lungs still really susceptible to RSV infection? And is the rate of hospitalization still pretty high? We decided that, okay, up until 8 months is approximately the time at which that risk, kind of drops off. Once you're over 8 months, your lungs have had enough time to develop in a healthy child, and you're not really at significant risk of being hospitalized from RSV. But for those babies under 8 months, that's where they're still at risk. And so we started to offer this vaccine and expand its use for all babies under under 8 months of age during RSV season, which is essentially October through March. So if a family has a baby and that baby will be under 8 months during RSV season, then they're eligible for this RSV vaccine, which is just one dose and offers really great protection against these risks that we've discussed, including hospitalization and death. I just had a family who had their second baby, and the baby was only 7 days old when he got RSV from the older brother, who's like a 3-year-old. And unfortunately, he developed a lot of difficulty breathing. They took him to the ER. The baby was hospitalized for about 3 days. And then the baby was sent home, but on oxygen. And it took about a whole week for the baby to be able to be weaned off of the oxygen at home, because it's a really prolonged illness. It's a good 7 to 10 days of intense mucus production that's blocking that oxygen. And again, in that baby's lungs, they're so tiny, it gets blocked really easily. So just not a fun thing for parents to experience, being in the hospital with your baby, watching them struggle to breathe, being on oxygen, having to get suctioned every 3 hours. It's not fun. So RSV vaccine is one that I really encourage parents to get as soon as they can if they have a baby during RSV season, because it's so protective.
Okay, I think we have one last quiz here. You guys can remember back into earlier in the presentation, what are retractions? You can put it in the chat or you can yell it out, whatever may be faster.
I was also going to say, Akram, if you can share the presentation to me, I can try and go back to those slides that had the sound.
Yeah,
So just email it to me and
let me
I'll
work
try to
on
do
that.
that.
Maybe we could have some people answer here. Okay, we have Zach saying breathing difficulties. Does anyone else want to put in an answer? Having issues with breathing from blockage, chest difficulties. This is tough. I don't know who I'm gonna give it to, but maybe I'll ask a follow-up question to this. Okay. Jonah, I think you may have the best answer here. Is what makes retractions different is you can see the muscles moving in between the ribs. So around the rib cage. I say I like that answer, breathing between the ribs. Lawrence, that's a more defined answer. Not sure who to give that one to. Maybe Dr. Ferguson, you help me out on that part.
I'll let Dr. Capella decide. That's the pediatrician here who effectively described what are retractions.
Oh man, that's a tough one. I mean, both of them are. I think you should do eeny, meeny, miny, moe. Because technically, both are good descriptions.
Yeah. Okay. Think we will. I hope this is not on me. The eeny, meeny, miny, mo.
Dr.
We'll
I
we'll
say
Ferguson.
give
we.
one to Jonette and we'll
Okay.
give one to Lawrence. How about that?
Yeah, I like that. Okay, so that concludes this presentation, but if there's any questions for that people have, I'm gonna go ahead and send these slides in, but please feel free to ask any questions about respiratory illnesses in children especially.
There's a question. Do you need to have all the symptoms in order to have RSV, or are there different RSV infections? So RSV is the virus, but any virus can present a little differently in different people. So some people just literally have a little bit of runny nose and congestion for a couple of days with RSV. That would generally be kind of, older kids or adults who are generally really healthy, hardly ever get sick, fight off infections really quickly. So it can be really mild. I would say more on average, RSV causes just a lot of that like mucus, a lot of that runny nose and congestion. And because you have so much runny nose and congestion, it can cause cough because all that mucus is kind of dripping down the back of your throat and triggering a cough as well. And also, just going down a little bit into your airway. But in older children and adults, you don't have that risk of plugging your bronchioles, plugging those little airways. And so you don't typically have trouble breathing. Now, that can be an exception in people with asthma. So if an 8-year-old or a 30-year-old has a bad asthma and they get RSV, it can trigger wheezing. It can trigger an asthma exacerbation or a flare up. So it can vary quite a bit. Again, we know that babies as well as the elderly can get those more significant symptoms leading to hospitalization, leading to much more prolonged illness and severe illness. Fever can happen, especially in the younger kids. I would say most older people that get RSV, because your body has already seen a lot of other viruses and infections in your lifetime, you're less likely to develop a fever if you're older with RSV, but kids do tend to get fever. So great question. It can be highly variable. Some people get sore throat every time they get sick, and some people don't. So there can be some variability for sure. The same with flu. Some people get lucky and they get influenza and, they feel sick for 3-4 days and then they're better. And some people get flu and they're knocked out for 2 weeks and they feel miserable with fever and body aches and, decreased appetite and chills and sore throat, runny nose, ear pain, all of that stuff, right? So it also depends on your underlying health status. If you are getting enough sleep every day, if you're eating well, including lots of whole grains and fruits and vegetables on a regular basis, if you are in a good space, kind of like emotionally, mentally, that all contributes to your overall health and your resilience towards any infection or any illness. And so you're more likely to kind of, maybe succumb for a few days, but then feel better, bounce back really quickly. Speaking of that, one of the best things you can do if you're sick is really increase those healthy habits, is eat, veggie soups and, eat those fruits and veggies. Don't just, lean on fast food and things like that, because your body needs that nutrition, especially that good nutrition, while it's doing the extra work of fending off an infection, of trying to combat an infection. Staying hydrated is also really important. Lots of us have decreased appetite when we're feeling sick, and so we're not as likely to drink a lot of fluid. But even if you don't feel hungry, drinking fluid can help your body combat the infection faster. That kind of baseline health status makes a lot of difference. Also makes a lot of difference, I notice, in people who respond strongly to vaccines versus people who don't. So some people, if your baseline health status is not as great, maybe you eat a lot of pro-inflammatory foods like fast food and hot dogs and sausage and processed frozen stuff, your body might react more strongly because it's already in a pro-inflammatory state to a vaccine. Whereas if you are someone who's eating healthy, getting enough sleep, feeling good, your body may have less of a reaction to vaccines. I see that a lot because I give a lot of vaccines in my pediatric practice, and I sometimes see that difference between kids who react strongly and kids who don't. It's not a universal rule. There are always exceptions, but that's something to consider. If you're someone who's like, oh, I hate getting the flu vaccine because I always feel sick after, hey, consider, you know what, for a week before I get my flu vaccine, I'm going to make an extra effort to sleep well and to eat healthy. And maybe that's going to help my body out. All right. Great questions, everyone.
Any other questions?
It's a good time, and I'll try to play these. Let's see if I can get this stuff to play. Audio okay? And let's try and listen to these sounds. Let me share my screen. Let's see if it works for me. Please let me know if people are able to hear this.
You can hear it.
Right, good, good. Do you see how the baby is, or the child, I should say, toddler here, is retracting? It's that sucking in that you see there. And then let's also take a listen to stridor. Now, stridor, often people will think about with what particular illness tonight? Sometimes we'll associate this with croup.
Nah, he don't.
Right. And here's grunting, in case we missed that.
Children who are struggling to breathe often make a characteristic grunting sound when they breathe out.
All right, did everybody kind of recognize the grunting there? And then here's croup. It's our barking like cough. Dr. Capella, you feel free to narrate through these. Any questions on those, or anybody wants to rehear
Yeah.
a
That last one was a combination. She kind of had that stridor going on and the barky, more of a high-pitched barky cough because she's a little girl, and so she just her voice makes it a little bit different. But yeah, that was a really great video there.
Then I think we had wheezing. See that high pitch, almost whistle. It sounds different when one is actually auscultating with the stethoscope, but this is what just auditory. We're showing this because this is what you're most likely to hear as a parent or caretaker at home, because the bronchioles are so inflamed and as it shows in that far right photo, it's so narrow that it makes that high pitched sound when they are doing what, Akram? Inhaling or exhaling?
Exhaling.
Yeah, it's kind of like if you've ever been in a big city like New York and it's a windy day and that wind going down a narrow like alleyway makes kind of like a whistling noise. It's the same thing. It's like instead of having lots of space for that air to flow, it's having to go through this really narrow space and it's making that whistling noise. Now, once you're able to hear it out loud like that without a stethoscope, it's pretty bad. Lots of times in the ER or in urgent care in the clinic, we will listen to a child's lungs and be able to hear it with the stethoscope, but not necessarily be able to hear it outside. You might be able to, like, if you lift up the child's shirt, you might be able to notice that they're working harder to breathe, but you're not always going to hear it on the outside.
There's a question in the chat.
With croup, um, it's not necessarily pain, but it's a lot of discomfort because they feel like, yeah, I can't get air. Like my airway is supposed to be nice and open up here around the vocal cords, and suddenly it's swollen. And so it can be really frightening more than painful because it's like, oh my gosh, I can't get air. Right? So kids can get anxious. That's why it's hard to keep them calm, even though we're supposed to try to keep them calm. But they can be distressed because of it.
But it doesn't necessarily, the child's not necessarily incurring pain. All right. I think that was it. We'll make sure that is shared out with everyone. Any last questions before we close out? I want to make sure that I share here. We do have another presentation that'll be coming up next month. This will be for colorectal cancer. So this will be out. If you haven't subscribed to our newsletter, there's also the Latinx Physicians of Utah has a newsletter as well. I recommend subscribing to both of ours. We both have quite a bit of health information, and our missions are aligned, and we support one another as sister organizations to increase the representation of Black and Latino doctors within the state. But that is our current, if everybody can see that.
Yep. I also wanted to answer a question in the chat. How long can viral infections last for babies under 6 months? Most of them are about a week, but plus or minus, like a 5 to 10 day sort of period is what's most typical for the peak symptoms. But some babies get lucky and parents are like, oh yeah, they had a runny nose for 2 days and then they got better, right? I would say though, most commonly, if it's like a legit viral infection, it's going to be 5 to 7 days most commonly. So within a week. And then sometimes it can last into that 10 to 14 day territory, especially with infections like influenza and RSV, which tend to be more severe. Also, what early warning signs should parents watch for before a respiratory illness becomes severe? I would say you never know if a cold is just going to remain a cold, right? A lot of us have had colds and we feel icky, but we're able to just drink extra fluids, stay home, take some cough medicine, do things like that, and we're okay. I just really watch their breathing. I would say that's the biggest thing to watch is like if at any point they seem to not just be coughing and not just have a stuffy nose, but seem to have increased work of breathing, meaning like any of the grunting, the retractions, the breathing really fast, and it doesn't seem to slow down after 20, 30, 60 minutes, then like that's a concern. If a child also is becoming dehydrated, so lots of times, especially with the high fevers, they're losing fluids faster. Just like, when we work out and our body gets hot, it sweats in order to cool us down. Babies are losing fluid at a faster rate when they're sick because of fevers. And so if a baby is not able to keep down enough fluids and they go more than about 8 hours without peeing, that's a concern that they're getting dehydrated and they should get medical attention. And then another one is just if they're not acting themselves, when they get really high fevers, they can seem really tired and out of it. But then as soon as that fever kind of wears off or you give them ibuprofen, Tylenol, they perk back up. That's normal. But if a child is just, for more than a couple hours, really out of it, not coming back to themselves, not being at all playful, not being interested in eating, drinking at all for more than a few hours, that's the concern and you should seek medical attention. But again, a lot of times it'll say just a mild to moderate cold, but breathing, I would say, is the thing to keep an eye on most. Any signs of difficulty breathing, it's best to schedule an appointment and get checked out or take your child to urgent care. If it's really severe, ER is best. I guess it depends. Urgent cares do a really great job. I used to work in urgent care. We would see wheezers, we would see croup, we would see all of that. ER is more for like, middle of the night. My child is like having a wheezing attack or just something like they can't breathe, they're barky coughing, cold air didn't help. That's when you want to go to the ER. But urgent cares can deal with a lot of this stuff pretty well. And if the urgent care thinks your child is too sick, they'll try to stabilize them and then they'll send them to the ER. So I do want to encourage people, don't go straight to the ER because an ER bill can be thousands of dollars versus an urgent care bill, which is hundreds of dollars. So that's something to consider as well.
And also consider depending on what practice you're with, there may be your primary care, your pediatrician may have an after hours line where you can actually get a nurse and you can discuss those symptoms with a nurse. Most insurance plans have a nurse line as well where you can discuss the symptoms and they can help you with that decision making on, is this something that I can wait to get in to see my pediatrician tomorrow, or is urgent care versus ED appropriate? And then there's a health care provider that can assist with that. Seems like we have another question here in the chat from Jessica.
Yeah, great questions, everyone. Jessica asks, can repeated respiratory infections in childhood affect lung health later in life? With certain infections, yes. So there have been some studies that show that babies who get RSV are pretty early in life, like in the first year of life, can have higher rates of developing asthma, for example. Now, that doesn't mean it's 100% risk. It just means that there's a slightly increased risk compared to children who did not get RSV in the first year of life. That's another reason to really consider that RSV vaccine and be extra careful. I always tell parents of newborns, hey, for the first 2-3 months of life, really try to minimize contact. Please don't take them to a Christmas party that has 70 people and everybody's kissing the baby and everybody's touching the baby, right? Or you have to get together, be really strategic about it, really careful to minimize contact because, a 7-year-old could be running around and they were sick last week and now they're feeling fine, but they still got a little virus that they're spreading through their nose and they don't know that and they just want to touch the baby, oh cute baby, and like they can accidentally spread it. So also I think some people just get really mild colds and they think it's just allergies. I've heard so many people say, oh, I'm not sick, it's just allergies. Like half of the time that might be true, half of the time it's actually a cold virus, and sometimes it's really hard to tell the difference. So yeah, so with RSV, there's definitely evidence to show some increased risk of asthma. I think with influenza also, because influenza just really does a number on your lungs. It can also have similar effects on increased rates of wheezing in childhood and maybe lasting into adulthood. The good news is that a lot of children do improve their asthma, even if a child has wheezing or asthma when they're younger. About a third of them outgrow it completely and never have problems in adulthood. About a third of them have kind of milder symptoms and only get asthma flares occasionally with a really bad virus. And then a third of people with wheezing in childhood end up with adult asthma. So it's not a death sentence in that sense. It's just, there's some risk, of course.
Good questions. Great questions. So everyone, just to keep you aware of things that are coming up, make sure you look to BPOU's Instagram, YouTube channel, our TikTok. We have a great intern, Kirabel, who was able to, he was getting people's emails and in the chat today. So once again, just want to make sure you're aware, colorectal cancer for the public, knowing the importance of screening. We're going to learn about some of the updates that have come out about colorectal cancer, especially how it's impacting younger adults. And then, of course, there is our clinical research internship for those that are graduating high school seniors, those in undergrad, and first and second year medical students. Once again, thank you everyone for your time this evening. We at LPOU, at BPOU and LPOU appreciate it, and we will see you next time. There'll be another presentation next month.
Take care, everyone. Thanks for your great attention and questions.
And this will be within a week's time on our YouTube channel, and it eventually will also be on our webpage under our community presentation tab, which I will show here for anyone that's remaining, although I told everyone that we are adjourned, we are officially over, but just so people know, there is a resource tab on our website that says, just so I can show everybody here, it's to go over to resources, community presentations. So if you don't see this on our YouTube channel, this eventually will be with our community resources. So you can actually even go back to some of our prior ones as well. All right. Thank you again, everyone. Good job, Dr. Capella. Amazing as always. Akram, great work.
Well done. Thanks so much.
Thank you, everyone.
Have a great night.
All right. Good night.